Make sure that goes down. And then I'm going to share my screen. Can everybody see that? Can you all see the?
Yes.
Okay,
Yeah.
perfect. Great. All right, so let's go ahead and start this puppy. So there were several questions about how to study for the exam. If you don't have this book, that's fine. You can get it at Half Price Bookstore if that's what you want to do. There's several different editions. This is their latest edition, which is the 9th edition. Not sure if you have this already in your resources, but this is another one. These are just specifically NCLEX study questions. So the difference between the NCLEX study questions and this one, the study guide with illustrations, that kind of gives you the lowdown of key things to focus on or know about a particular condition and what your roles and responsibilities are, even down to teaching. So there's a lot of, there's illustrated images or pictures of certain disease conditions that, you know, that we've already talked about, like the hypothalamus, you know, what's hyperthyroidism, and some of it was already in your PowerPoint online. So how to differentiate between conditions. This is strictly your, it's NCLEX questions. However, if you have the online version, so if you go and get the online version, then it will give you an outline of steps of things to do. And then it still has all of the study questions or all the NCLEX practice questions that you can do. Make sense?
Yes.
I'm presuming that's a yes, because I hear nothing. All right, so, you know, how do you study? Start today. So basically what we're preparing you for is NCLEX, and as an entry-level nurse leaving our program, that should be your ability to function. So when you're taking like HESI and NCLEX exams, they're like the perfect world. You have the ideal hospital setting, you know, all your orders would be there, everything of what you need would be available, okay? The textbook is based on, or the questions are based on the textbook's practices. So overall, whether you have, you know, Lippincott series, whether you have an Evolve series, whether you have a North Carolina series, a Saunders series, it doesn't matter. Textbooks relatively run the same. So there's a few tweaks here and there, but in the grand scheme of things, they have to have the general information for you all to be successful. Whether you're taking the test in Maine or taking the test in California, it doesn't matter. So it's not necessarily the real world. Everything is about the patient and their care, their management. That should be your primary focus, okay? You know your normal lab values, you know, for common lab tests, like your Chem 6, sodium, potassium, chloride, BUN, creatinine. For your CBC, you should know your white cell count, your platelets, red blood cells, hemoglobin and hematocrit. Certain disease conditions would include like your differentials, like your SED rates. So you need to know them. We talked about normal lab values for nutrition. So the HDLs, the LDLs, blood sugar. So that's what they mean by common lab tests. That's what they're speaking about. No values in diagnostic procedures that indicate whether your patient's getting better or not getting better. So if, you know, the potassium was 2.9, then we know that we're in trouble. Or if the potassium was 6.0, we still know we're in trouble. Mm-hmm. Does that make sense?
Yes.
Okay. There will be math calculations. So this is the reason why You have the math calculations test. You have to know how to do your IV rates, your drip factors, your medication dosages, and INOs. So you just can't, fudge on it. You can't say, well, my INOs are roundabout, especially if the patient's on strict INOs. Then every time they put something in their mouth, or every time you even, say you're going to flush the IV site, those things become super critical when you're trying to balance, fluids. Key thing is don't memorize questions. So when you're doing these practice questions, don't memorize the questions, but look at the rationales. Look at why that answer is the correct answer. And in the rationale, it will explain if the other answer choices belong to another condition. Therefore, that helps you understand information about that condition as well. So if you're memorizing NCLEX test questions, then it's kind of like you don't really understand what you're doing. Make sense?
Yes.
All right, so questions. When you're reading, and even this is for our exams, when you're reading the questions, start from the beginning of the question and then read it all the way through. Even if you think you know what the question's going to say, prove yourself right or wrong. It may start off, you may understand what you think the question's getting ready to ask, and then at the end, there's a change in what they're really looking for. Do not read into the question. That means don't do the what ifs. Okay, so just read the question as is. Check for words that indicate there's a priority, like what's your first nursing action, or what's your priority nursing action, the most important intervention at this time, or most important teaching. Does you understand that portion?
Yes.
Okay.
Yes.
Is the question positive or negative, or is the statement negative or false? So basically, you're trying to figure out, what are you really answering to? If blah, blah, blah is not working, or so-and-so is a contraindication to X, Y, and Z. Things to avoid, and, dietary practices to avoid in a patient with, hypernatremia. How do you know the patient doesn't understand, the dietary regimen involved in someone that has coronary artery disease? So know what the question's asking. And remember, if there's a positive to something that should all be negative, then the whole answer is incorrect. So the whole answer has to have all of the items to be a correct answer. I hope that makes sense.
Yes.
It does.
Timing words. This lets you know when certain things need to be done, like immediately post-operatively or immediately post-op. Patient has experienced X problem this morning, or they had X problem last night, or X problem this evening. In the first few hours, what would be your priority nursing assessment?
Mm-hmm.
In the first few days, what would be, best teaching practice? Or upon discharge, what would you say, what would be the teaching you would do for your patient in reference to, we'll say diabetic management? So we all should know the nursing process, ADPI. So assess, diagnose, plan, intervene, evaluate. So before, if you're read your STEM, determine what it's really asking. So you need to have an adequate assessment data before you move through other steps. So you can't do intervention and you don't know what you're intervening for. So if a patient, somebody says, oh, Mr. So-and-so, fell, he has a bunch of bruises. So do you take that at face value, or do you go in and do an assessment? That's a question. What should you do?
Go in and do an assessment.
You should go in and do an assessment. because you need to know what other areas have been injured. I mean, maybe there's a fracture. Maybe he or she hit their head. So does the STEM provide adequate enough information for you to determine what nursing action or intervention or plan needs to be done? Is it really asking you to do further assessment? So don't focus on predicting the right answer. Focus on what the question's really asking you to do. So just in case you don't have the ad pod, I put it together here in this video, in this PowerPoint presentation of, what does it mean? So gathering more information about the patient's condition, identifying the patient's problems would be the diagnosis, set goals of care and desired outcomes, and identify appropriate nursing action as your plan. Then you put that plan into action. So whatever you say you're going to do, I'm going to, give antibiotics. Okay, now we give it. And then evaluate, determine if you met your goal or not. Does the patient have the right outcomes that you were expecting? Did they not? So patients don't always get better regardless of what we do. Sometimes they get worse. Sometimes the condition is a lot more serious. Sometimes condition changes. So you have to remain flexible. Therapeutic nursing process, more communication. So sometimes the patients that you receive, even on the exam, are not all psychiatric clients, but you still have to have appropriate communication. So, your responses should focus on the patient's concern. So again, the patient says, well, once I, if I stop taking this medication, then, if I stop taking my high blood pressure medication, I won't have high blood pressure anymore. So once I start taking it, I don't have to take, I'm good. I don't have high blood pressure. You still have it. Well, once I take these medications for COPD, I no longer have COPD. Yes, you still have it. Look for open-ended responses or ones that help the client to express themselves. Eliminate responses that are not honest or, indirect. So if it's not honest and direct, then move on. We're trying to stay away from opinions. Look for responses that also indicate patient acceptance. The patient states that they will check their fingerstick blood sugar as, ordered by their physician. Don't select options that block further interaction. So if they're, that means whatever option you choose, there has to be more intervention, more evaluation, more assessment. So if you choose an option that just stops it, then that's usually not the correct answer choice. Look for responses that either reflect or restate or paraphrase feelings, and this is all about therapeutic communication. Never ask a client why they feel the way they do. I mean, they have the right of autonomy to feel whichever way they so desire. And we're never going to try to coerce a person to achieve a desired response. We're just going to educate and encourage. So if they are, set on doing something different, then so be it. Tips. Try not to indiscriminately change your answers. We talk about this every semester. You probably heard it first semester, and you'll hear it third and fourth semester. What that means is, if you read the question thoroughly, you selected an answer, and you've eliminated all the others, then stick with the answer. You will 90% of the time change your correct answer to the wrong answer if you go back and self-guess yourself or second-guess yourself. So once you choose an answer, then it's it. But rarely do you ever change a wrong answer to a right answer. Sometimes that does happen, but the majority of the time, you will usually change your correct answer to the incorrect answer because you did the what ifs. Watch your timing. Don't spend too long on a question. Eliminate distractors. Okay. On any health care exam, allied health exam, you will always narrow it down to 2 answers because the other 2 just sounds totally ludicrous. So when you get to the last 2, because they're very similar, go back to the stem of the question and look at what is it really asking you. Does that make sense?
Yes.
And that's how you pick your answer choice at that point. Okay, say for instance you chose incorrectly. You're going to be upset, get that. But look at it this way. You were able to narrow it down to those 2, and now you understand which one makes it the right answer and why. So if you have that concept again, you'll understand it a little bit better. And this is why we don't change answers.
Mm-hmm.
Don't assign the step of your nursing process steps or judgment to anyone else except an RN. So this is about delegation. You're teaching anything that's in the nursing process, you cannot delegate that out except to another RN. Your teaching assignments, again, that goes to another RN. And then you have to be specific about what you want done. Look at what clients are priority. Identify your priority client. So that may be, you are the charge nurse for the day, and this is your patient assignment. Which patient would you choose first? Which patient is your patient of priority? So, as you go through report, and if you're getting report on 3 different people, and as they're going through what's been going on with your 3 patients, then I usually circle the things that are abnormal. And then I start using a priority checklist, which we're going to talk about in the upcoming slides. So circle all your abnormals, whether it's lab values, whether it's airway issues, whether it's breathing issues, whether it's a circulation issue, and then you compare apples to apples to apples. Airway is important, but maybe that if the airway is patent, then that's not a priority. We already have a patent airway. So your priority clients are those that are likely to, have more problems or ill effects. So maybe it's respiratory compromise. Maybe their condition continues to change. Maybe they're unstable. Maybe their vital signs are too low. They're more likely to develop, serious complications like cardiogenic shock or any form of shock for that matter. So that's how we're looking at priority patients. So remember, in report, as you're hearing it, then circle things that are abnormal. So first things first, Maslow's hierarchy of needs. These are physiologic needs. They have higher priority in the psychosocial or teaching. So we got to meet those physical needs first. That's the airway, breathing, circulation. Don't just select the airway, as I just said before, just because it's first. Does the patient have an airway problem? If they don't, we're moving on to breathing. If they don't have increased work of breathing, then we're going to move on to circulation. So maybe, they've had several rounds of diarrhea. That's a volume problem. That's a circulation problem. So that circulation would now become the priority in that aspect. So for an example, assessment. So you have to analyze, you have to do an assessment so you can determine what nursing diagnosis, your plan of care, your interventions need to be done. So if in your assessment data, or in your question, if your assessment is in the STEM, then start looking at Maslow's hierarchy of needs. If the nursing action has been implemented, then focus on evaluating the effectiveness of the action. So if, the patient's already been given oxygen, then look at, are we having any further oxygen compromise? And besides oxygen sats, look at, does the patient has adequate breathing? Do they have, clear breath sounds? Are they showing signs of respiratory compromise? Does that all make sense? Yay, nay, thinking about it? Okay.
Makes sense.
Safety issues. This can be whether you're in or out of hospital. meaning in the hospital or the client's environment. So things to consider first, the patient's oxygen status, is it good? Hydration status, is it good? Nutrition, and then elimination. So those are the basic needs of survival when we're looking at safety. The other portion of safety is looking at the patient's environment or in hospital as well and outside the hospital. Fall prevention, medication errors, accidents, like having someone go home and they're on 3 different anticoagulation medicines. So they're taking aspirin, Plavix, and something else. It's like, okay, wait. Can they just take one and be A-okay? The other portion of environmental safety would be, prevention and the spread of contagious diseases. So hand washing, vaccinations, donning your PPEs. If you have a patient that has tuberculosis or someone that has C. difficile, so someone that's on isolation precautions, or if you have a baby that comes in and they have meningitis, putting them on isolation precautions. So those would be environmental safety rules that or considerations that you would, have to understand. And so as we talk about some of these, we'll talk about what's priority, in that aspect. So if the baby comes in and, gets to your floor, you need to make sure they're in isolation, okay? So look at what's going to be the most beneficial to the client. Once you answer the question, reread the question in your answer choice and then move on. If you're looking for zebras, and what I mean by looking for zebras, that means all the what ifs. The only place you should see zebras is either at the zoo or if you go to Africa. But if you're I haven't seen a zebra yet walk down the streets of DFW. Now watch somebody go find a zebra and put it walking down the street. So don't worry. Study tips. Study in small increments. So don't try to, like next weekend, don't say, okay, I'm going to spend the whole weekend studying. Incorrect. Because if you do that, what's going to end up happening is you're going to become overloaded. And you're going to start panicking. And any information you would have learned is literally going to go out of your mind. Your brain is literally like a sponge. You have to treat it appropriately. If you just keep pouring water on a sponge, it's just going to seep out. So you have to study in smaller increments and then review every day. Review the material you studied the day before. You have raising the bars in your course board. Do them. That's what helps you get prepared for studying. And it'll help you prepare for HESI at the end, and it will also help you prepare for NCLEX. So have an understanding of conditions and diseases, the contrast, what makes them different. At the end of class, what I usually have you do the last 5 minutes, explain to your neighbor what you learned from the lecture. But after class, review your notes for about 30 to 45 minutes to start that long-term, putting those things in long-term memory and not short-term memory. Have a study plan. Know when you are more likely to learn and retain information. If that's at 4:30 in the morning, then it's at 4:30 in the morning. If your brain turns on at 9 o'clock at night, okay, then 9 o'clock at night it is. But if you're tired from the day and you're trying to study at 9, you're not going to be as effective. And pick the days to study and then stick to the plan. If you're going to study 3 to 4 hours a day, then, if you were going to study metabolism, then I would look at all the material related to metabolism. And then I would say for the first hour, I'm going to look at diabetes. So I'm going to look at signs and symptoms. I'm going to look at interventions. I'm going to look at expectations and my medication. So the pharmacology. Then I'm going to take a break for 5-10 minutes, give you enough time to make a sandwich, use the restroom, get something to drink, smoke a cigarette if that's what you do. And then you come back and you review that diabetes material, and then say for the next hour, I'm going to study hyperthyroidism. So I'm going to spend that next hour studying hyperthyroidism, and then that includes signs and symptoms, assessments, you know, the etiology, and the pharmacology. After that, I'm going to take a 10-minute break, and then I'm going to come back and review diabetes and then hyperthyroidism. And then my next hour, I'm going to study hypothyroidism. And I'm going to keep that same chain going up to that 4th hour. After that 4th hour is up, then I'm going to take my 10-minute break, and then I'm going to review the material from hours 1 through 4. And then I'm going to go on about my day. Before you go to bed that night, then review all of that material again. Next day, if you're studying, then review everything you did from day 1, and then start your new hour with and you continue that process. That's how you start putting it into longevity. And then you'll find you're able to remember or understand how certain conditions work and what makes them abnormal and what to look for. All right, study goals. I just covered number 1. You can prioritize your segments. Maybe, you know, I would study the things that I didn't understand the best first. So say if you have difficulty wrapping your mind around, you know, DKA, then I would start with DKA. Or if you had difficulty wrapping your mind around HHS, then I would study HHS first. Because the things you actually understand well will be an easier flow. But always do your most difficult stuff first. Do practice questions. How many practice questions do you think you do in a week? Anybody?
I myself, I practice 30 per day.
How many do you do?
I do 30 per day.
30 per day. Okay. 30 to 40 questions. I don't know if you could do them per day, but at least definitely per week. I can see that. That's manageable. So I'd look at the study questions related to the exemplars for which you're studying. That'd be a good way to go about that. You know, but don't try to memorize those questions. You need to understand why they are, why the answer is that, what made that answer choice, you know, the one over another answer choice. And then set realistic goals. Set realistic schedule, you know, when you're going to study. You know, if you've worked a 12-hour shift, or someone to go home and study, more than likely by the time you drive home, you eat, your body's like, whew. So maybe the next study time may not be into the morning. But don't overbook your schedules either. Overbooking your schedule makes it more difficult for you to study. And then that puts you in that category of having to study on the weekends only, and you're trying to body slam it all in. Now, that may work if you're doing it every weekend and not just the weekend before the test. Study groups. I highly suggest doing study groups with this caveat. You cannot have any cinder blocks in your study group. What do I mean by that?
Dead weight.
I can't hear you, babe.
People who haven't prepared?
Exactly. Folks that come to the study group haven't read the material or anything. They cannot be a part of the study group. When you come to the study group, you have to come prepared. You have to come with your materials ready to go. Everybody has to be committed to the process. And you need to have an effective mix. Sometimes it's better to have the person who may not understand it that well because they may actually have another section that they really get really well. If you have a chatty Kathy or, you know, a chatty Nathan in your group, I'm just going to tell you, get rid of that person. The, you know, negative Nancy, Debbie Downer, that group, get rid of that person. You cannot be effective with all those other distractions. Serious business. You all are talking about taking care of people with, you know, a multitude of conditions. So you got to be serious about what you're doing. But I wouldn't have more than 4 people to a group. Because too many people, then you start talking shop, and then it goes in a whole nother direction. Some people study better by themselves, and that is totally okay. So I'm not telling you you must do it, but I will say study groups do help because sometimes you think you understand something, and when you run it by somebody, then you're like, oh, I missed that. So it's always, that's why I do that at the end. So that way, if you see if you've all heard the kind of the same thing. Questions?
I have a question.
Okay, speak up so I can hear you. And there's somebody, I'm so sorry, that their phone is, can you mute your phone? Because there's a lot of scratching that's going on, and it's very hard for me to hear the person that's asking questions.
Oh, are you talking to me?
No. I don't know who it is, but I'm trying to hear the question that came through, but I can't hear your question because someone else doesn't have their phone or their computer muted, so I hear all of their activity. So go ahead with your question.
My question is, for example, while we study for parathyroid, do we have to cover like hyperthyroidism too? You know, when we read the book, you know, when you study the parathyroid, you know, when you finish thyroid, you will see parathyroid. So do we have to cover those two in order to prepare for the exam?
What you have to understand about the thyroid is that if it is damaged or weak, those parathyroids are definitely going to be affected. Now, in your course board for metabolism, what I would do, if you want to know what's expected, then you look at your exemplars. So for metabolism, it's diabetes type 1 and 2, gestational diabetes, Graves' disease, which is hyperthyroidism, then hypothyroidism, and then Addison's disease and Cushing's disease. So that's what you're responsible for. When we get to fluid and electrolytes, that parathyroid's going to come back up.
Okay. What about thyroidectomy? You know, when we study still for thyroid, there is one of the, you know, treatment is thyroidectomy.
Correct.
Still include that one too, the thyroidectomy too.
Listen, when you're studying for a condition, then or any exemplar, if a treatment is a surgical procedure, you have to study that because the patient may not necessarily be able to be treated with only medications. So you have to know what the thyroidectomy is and how it's going to impact your patient. Does that make sense? Does that answer your question?
Yes, it does. Thank you.
Okay. Any other questions? So remember, you just can't say I have hyperthyroidism. It's the thyroid. You know, if I have hyperthyroidism, that means I have a lot of thyroid hormone, and I'm going to take these medicines. You have to know the assessment to it. You have to know, you know, if they decide to take it out, what's going to happen to the patient. You got to know all of the treatment modalities, the common ones. So if in your material, which it does say, because we covered it on Tuesday, if it says for hyperthyroidism, we're going to do a thyroidectomy, then your concerns related to the thyroidectomy, sometimes patients have those, and because of the proximity of the larynx and the voice box, they may actually, you know, damage the nerves or damage the vocal cords. So that person may not be able to, may not get their voice back, or they may have to go through speech therapy. So that's why you have to, you know, you do have to know about thyroidectomy and the impact that it can have. So you just can't ignore that. Are there any other questions about the study tips, etc.?
I still have another question.
That's fine.
Actually, when I try to read the book, it's gonna take me a very long time to cover the whole thing. So, do you have any tips, you know, to study reading the book? You know.
Okay, so if I'm going to read the book, then what I'm going to do is look at the exemplars that are being studied. So if you're looking for a shortcut, I'm just going to tell you, you're wasting your time on that. There's not a shortcut. So when you're reading the book, you have to read it and understand what it's saying and take notes. If I'm reading a particular section in a book and it's huge, then what I'm going to do is paraphrase it into my own words that I understand, so that way I can I have a general gist of what's going on in that section. Does that answer your question? Hello? Does that answer your question?
Yes, thank you.
Okay. I'm going to ask another favor. I'm sorry, but there's about 4 people. I'm not sure who it is, but there's a lot of movement. So can you mute your phone so that way I can hear what's being asked and the person can hear me back? Because there's a lot of, I don't know if it's wind or what. So if you go down to the bottom of your screen for your Zoom session, then a row will pop up, a little tab, and mute is on the far left. You can still hear me, just mute yourself. Did you have a question, Sydney?
Oh, no, I don't have a question.
Okay. All right, so before I go on to the next piece, what questions do you have?
I don't have any.
No, not you specifically. I'm just asking in general.
Okay.
So nobody has a question. Okay. All right, so we're going to move on to the next piece then.
Oh, you know what, Ms. Hudson, I do have a question.
Okay.
I was looking over the types of insulin that diabetics would take, and I was actually confused because there was an R at the end.
That's regular insulin.
So so I was really confused. So would that be rapid or would that be short?
That is a short, if I remember correctly. The rapid was like your Lispro.
So anytime there's an R at the end, that means it's going to be short.
Okay, the R means that it's regular.
Okay, so anytime it's regular, I'm guessing it would mean short because that's why I was like, oh my God, like I think I'm okay like with the diabetes part, but when they started talking about the insulin and like the duration and the peak and the onset, I was like, okay, I'm lost.
So remember, I provided you a slide on insulin.
Mm-hmm.
So hang on one sec. So remember this slide?
Yes.
Okay. So I put off to the side what would be, you know, your rapid, which is your Lispro, your Aspart, your Apidra, but your Novolin R, your Humulin R, that's regular insulin and it's short acting.
Oh, okay.
So your intermediates have your N's at the end. So Humulin N, Novolin N, that's going to be your intermediate acting. So that's why I put it there so that way you wouldn't have to stress yourself over that part. Make sense?
Okay.
So if it's just plain Novolog or Humalog, those are rapids. If it's your Humulin and the R is on the end, then that'll be your short acting. And that may have been what you're asking. But I wanted you to know that the R meant regular insulin.
And it's going to be short.
Yes.
Ms. Hudson,
Yes.
did you already make this available on Blackboard for us?
I emailed it to you directly.
Oh, okay.
Check your email. Also go to Clutter. Check your Clutter. I sent it out last night, probably about 8:30.
Okay.
Okay.
And the NPH is going to be intermediate.
Right. It's right here.
Mm-hmm.
Okay. I got that down.
So what I showed in the PowerPoint was Levemir or Lantus. Those are your longer acting ones.
Mm.
Go with L's for Lantus and Levemir, long acting, if that's the way you want to remember it. So that was the next slide. Oops, go back.
Oh.
Okay.
Okay.
All right. So let's see how well you all have been studying. We're gonna put this to the test. I'm gonna share my screen. Okay, someone says that noise is driving me crazy. So this is coming from your classmates. So this will be my third time asking to please mute your phone, mute your computers, so that way everyone can hear fairly. I'm getting ready to share my screen. Oh, there's 6 people now. Here we go. Share screen. Oops. And we have that one. Perfect. All right, so can you all see the case study?
Yes.
Yes.
All right, hold on. Doesn't matter. All right, well, let's see. Escape again. I don't know why this wants to be that. All right. Go here. Move that there. All right, so here we have a scenario. We have someone with diabetes, mellitus. They go to a treatment center and a teaching hospital. So the patient is KW, a 40-year-old Hispanic female who was seen 2 years ago with severe fatigue and blurred vision. She thought this was due to working long hours at a computer. The physician who examined her told her that she had borderline diabetes, put her on a 1,200-calorie diet, and told her to lose weight. Her records from that visit indicate the following. She weighed 205 pounds. She was 5'4", blood pressure 140/90, urine normal, fasting glucose 118. Okay, so based off of that, do you see any other concerns?
Her vision.
Speak up for me, please.
Her vision.
Her vision is a concern. Perfect. What else?
Blood pressure.
Her blood pressure is definitely a concern.
Mm-hmm.
Okay, and someone type that in. Thanks, Andrea.
Yeah, and you know her weight.
Her weight's a concern. You know, for her small stature to be 205 pounds, right? Okay.
Mm-hmm.
And
All
her
right.
fasting glucose level?
Fasting glucose is not that bad. That's why he said she was borderline.
Yeah, okay.
Mm-hmm.
Okay, so the correct term for borderline diabetes is either impaired fasting glucose. Doesn't that sound like a nursing diagnosis?
Mm-hmm.
Or impaired glucose tolerance. Another term commonly used is prediabetes. How would you explain the term borderline diabetic to KW?
Okay. What does KW stand for?
That's the patient's name.
Oh. Okay. How would I explain it to her? I would explain it to her, by telling her, that her sugar is like, it's high, but it's not high. And we want to control that with diet and exercise.
Okay. Anybody else?
Okay.
Oh, I didn't know you were finished.
No, I was just going to say we would probably want to decrease the fats that she's eating with maybe avocados, like in the nuts and the seeds. I would really more so focus on her diet and
Okay.
exercise.
All right. So one of your classmates stated that she is at risk at this time if she doesn't begin with the regimen that the physician has provided. So I'm presuming she means at risk of developing diabetes.
Mm-hmm. Type 2.
Correct. All right, so the term borderline means you have either a fasting or random glucose higher than normal, but not high enough to be diagnosed with diabetes. Prediabetes is not a type of diabetes, but carries a higher risk of developing diabetes at a later date. And so just some statistical data, it's estimated that we'll have between 20 and 30 million folks that are totally, right now, that are pre-diabetics. Okay. All right, so what's the criteria for the diagnosis of impaired fasting glucose or impaired glucose tolerance? Anybody?
Yeah, I was gonna say anybody. Let me run upstairs and grab my notes. Came back. Anybody? Anybody?
Someone says if you're pre-diabetic, does that mean your insulin production is starting to be affected? Yes, you're starting to have insulin resistance. For the impaired fasting glucose at a certain level, fasting glucose greater than 126. So that's what they're listing the criteria. So IFG is the fasting glucose less than 126 but greater than 100. Impaired glucose tolerance is a random blood sugar of 140 to 199. So that would be your criteria. What laboratory value indicated that that KW had an impaired fasting glucose or pre-diabetes?
Oh, her blood glucose, it was at 118.
So,
right?
Yep, that her fasting glucose was at 118. What recommendations would you have made to KW to minimize her risk of developing diabetes in the future?
Diet and exercise.
Okay, like what?
I would tell her to do aerobic exercises. Her diets, I would more so want more proteins instead of fats. Carbs. I don't know any good carbs.
Somebody said walking, low glycemic diet. That's true. Diet with less fats and sugars. That's true. So lose weight. Refer to a registered dietitian for management. So diet higher in protein and healthy fats and lower their carbohydrates. Lower the glucose and weight loss. ADA diet. High cholesterol or high carbohydrate diets will only increase the glucose. It will also increase the triglycerides and increase the patient's weight. Exercise on a regular basis and follow up with the physician in 6 months. Okay. Okay, so here is a progress update. So what do you, she didn't think she had a problem and she ignored the physician's advice. 3 days ago, she went to see the physician after 1 month history of frequent urination, thirst, fatigue, and some burning and tingling in her feet. She smokes, so we didn't know that before. She doesn't exercise. Diet is mostly fast foods, and foods cooked at home are high in starch and fat. Her work schedule, because of her work schedule, her meal times vary day to day. Family has a history with her father dying of a myocardial infarction in his 40s. Mother suffers from diabetes and high blood pressure, so she definitely has familial history. The labs from her physician, she's 215 pounds now. Random glucose 210. Next day fasting glucose 135. So her HbA1c is 9.5%. Is that normal?
No.
Okay. Cholesterol 310. Triglycerides 300. Her HDLs are 25 and her LDLs are 160. Ratio 12.4. Her creatinine 0.9. BMI is 37.6. Blood pressure is elevated. She's now diagnosed with type 2 diabetes and started on metformin for the diabetes, lisinopril for her hypertension, and simvastatin for her hyperlipidemia. So Now she needs comprehensive education. What lab values are diagnosing the type 2 diabetes?
Well, her blood sugar for one.
HbA1c over 6.5% is random glucose 210 and fasting glucose 135. Would you all agree?
Yes.
Yes.
Okay. So we got the 135, a few yeses, 210. Correct. What does HB mean? Blood or hemoglobin?
Hemoglobin?
Hemoglobin. So it is blood, but it's the hemoglobin. All right, case study progress. So your educational materials cover 4 basic areas: medical nutritional therapy, exercise, glucose monitoring, and pharmacotherapy. So identify important points to be covered under the medical nutrition therapy. What do we want to talk about for nutrition? Portion sizes, I agree.
Yeah. Portion.
Checking her blood sugar on a regular basis, how to manage her diabetes herself.
Yes. Checking her blood sugar before she exercises.
Okay. So meal planning, or we're going to help maintain the glucose levels within the target range as much as possible. A healthy lipid profile to reduce cardiovascular disease. Keeping blood pressure less than 130 over 80. Why we don't want it lower?
I'm sorry, because in the book I didn't catch anything about blood pressure. Let me see. Maybe.
Why is it we don't want her blood pressure to be lower? Because she's on blood pressure medicine. So why is it we don't want it like in the 110s?
Well, wouldn't it cause like a stroke or a heart attack?
It can cause her to have a stroke or a heart attack, dropping it too low. So they're going to leave her at the or pre-hypertensive area, just not too low. Okay. But keeping it to help reduce the risk of vascular disease because she can develop other issues. Past family history and coronary artery disease also has to be accounted somewhere in there. I agree. Let's see what else is there. Oh, okay. Moderate weight loss, 10 to 20 pounds, has shown to have lowered the effects of high blood pressure and glucose levels and lipid profiles. So wasn't she 205 before?
Yes.
So she's put on 10 pounds. So she lose those 10 pounds or 20 pounds, that would be helpful. Several meal plans are available, but carbohydrate counting at a basic level, so 45 to 60 grams per meal is, kind of preferred. Having a consistent intake of carbohydrates and also consistent meal times, portion sizes, and dietary fat modifications. How many meals per day should you eat anyway?
Well, they say at least 6, like small meals per day.
So you should have small, frequent meals. Your lunch, breakfast, and dinner would be the bigger of the 6. The rest of them are basically snacks. So 4 to 6 small meals is true. So snacks could be like, carrots and celery, something like that. Not a bag of potato chips though. Would that be okay?
No.
Walnuts, that's good. That's a good option. Cashews, almonds. So if you like almonds, that's a good one. That could also be a part of your meal portion size, or fruits. So raisins and dates, that can be added into your small meals. For exercise, it can be low impact. You don't have to, get what's that Shaun T's videos, insanity videos. Somebody that's 215 pounds, they're going to get discouraged very easily on Shaun T. So they just need to start with some walking. Walking is a good place to start. After basic nutritional guidelines, then we're going to refer them to a dietitian, and then they also need to be taught that, sick day guidelines for taking medications when illness interferes with nutritional intake. So they don't stop taking it, they have to keep taking it and do the best they can still, your soups and so forth and so on. All right, so next part. Identify important content to be included under exercise. So potential benefits, precautions, and recommendations.
As far as exercise, like aerobic exercises, walking, swimming, jogging, as long as it's low impact, it should be okay.
All right, so we want to make sure they wear the proper shoes. So you can't wear those $1.99 sneakers to do any, real walking. You need, some good supports, cardio, drinking plenty of water, long-term aerobic, regular exercise or activity. So based on their level of capability, depending on the weight, aim to have a healthy amount of weight loss per month. At least walk for about 30 minutes or work up to that level. Those are all good suggestions. Improve strength and work capacity. Instead of doing princess parking, I call it peasant parking. That's where you're at the back of the parking lot instead of in the front. Careful when choosing snacks and foods because that, due to decrease of the blood glucose during exercise, but actually having some available just in case your blood sugar level drops. Decrease risk for coronary artery disease by lowering the cholesterol and triglycerides. A lot of folks feel that the medication is going to do it all, but truthfully, the medication is helping, but they also need to do their part and not just, still eating a whole pig. Have them check the bottom of their feet when putting their shoes on. We talked about that in lecture. Let's see.
Shouldn't they wear just white socks?
Why white socks?
I don't know, because my dad, he's a diabetic, and the doctor told him he should only wear white socks, not any colorful socks.
Well, why white socks?
I mean, I don't know. That's what I'm asking because
no,
that's
I'm
what he
asking
told
you to
him.
think through it. Remember, if they don't look at the bottom of their feet, what would white socks tell them versus brown, black, or blue?
Oh yeah, if my dad stubbed his toe, he would probably see the blood.
Exactly. So blood, which someone else has already said, possible wound. So if you had an ulcer, you could see the discoloration if they had pus or anything coming out of a foot ulcer. So that would be the reason why to have the white socks versus a colored sock. It's the same reason why you should not have black gloves. They're cool and cute, but it can't tell you if you have blood on your hands. Make sense?
Mm-hmm.
Okay. Other therapies to control high blood pressure, like decreased salt intake, staying away from deli meats, because those are high in salt or processed foods. We did talk about the ramen noodles. We talked about that. So things that are high in salt, have a high salt content. Check the labels. And then build strength and endurance. Other changes, for the body composition would be to do reduce weight and body fat, just kind of improving the health overall. Those are all the potential benefits. All right, but here's problems. Hypoglycemia after exercise or during exercise for those that are on insulin or oral meds. Patients with cardiovascular disease, PVD is peripheral vascular disease. We talked about the retinopathy, the neuropathies, or nephropathies. So that's in the kidneys, right?
Mm-hmm.
So they may have some restrictions. Earlier, someone mentioned that they had early signs of kidney compromise, and that is true, with the creatinine being 0.9. So let me tie that in. The ADA recommendations: avoid activities when fasting glucose levels are more than 250 and ketones are present. So use caution in postprandial glucose levels that are 300 with no ketosis. That means no ketones. Recommendations, check blood sugars before and after exercise to prevent, DKA if you are an insulin-dependent diabetic. Talk to your providers before starting an exercise regimen to make sure it's the right one for you. Find an activity that's safe. You should start slow and get up to that hour per day. So you can do that into 3 10-minute sessions, so you don't have to do it all at one time. So that's actually an average of 30, correct?
Mm-hmm.
So they don't have to do the full hour. No, the doctor says a whole hour. You may not be ready for the whole hour. You may have to work up to that point. Try to do something 3 to 5 times a week. Warm up and cool down periods. So before you just get in there full throttle, you need to stretch your muscles and all of that. Make sure they're nice and limber. And then you also need to stretch them afterwards so that you don't end up with Charlie horses, right?
Mm-hmm.
Check your blood sugar and blood pressure as directed by the physician. Those that are at risk for hypoglycemia need to carry a glucose source, so hard candy, juice, glucose tablets. All right, I think that's going to be it. Number 8. Identify important content to be included under glucose monitoring. So what do you want to tell your folks?
As far as checking their sugar, their blood sugar?
Yep, how to monitor it.
As stated earlier, check it before and after exercise. Check it before you go to bed, when you wake up.
Before and after eating, someone said AC and HS, so that would be morning, that would be lunchtime, dinner time, and at bedtime. So that would be your AC and HS.
Mm-hmm.
What if you're feeling dizzy? Should you check it then?
Yes.
Absolutely. Figure out what's going on. So it tells you, feedback about meeting and maintaining your glucose levels, how to detect and prevent hypoglycemia, evaluating responses to different types of food and activities. This gives you information to your provider if they need to change your treatment plan. So, physicians will start you at a particular level, but they have to monitor if this level of insulin or this level of the oral agents are working for you. Have a simple carb or sugar available with protein so that way you can maintain your blood sugar in case it does go low. A diabetic educator to assist in choosing the best meters for them, teach them the proper way to use it, to clean it, to test it, the glucose strips, etc. Cost involved, the cost factors with supplies. If they need to get needles, then where to get them from. Pharmacy usually gives that to them. The ability to use it based on their dexterity or their vision, and the accuracy of the glucometer. So identify important content to be included under the pharmacological therapy. So this would be like the insulins, etc.
Well, with the insulin, doesn't it all depend if they're type 1 or type 2, or?
Like insulin pens are easier for some with eyesight issues.
Oh, you want to instruct them on where to give the insulin shot at?
Exactly.
Okay.
I had a student that actually had, it was an insulin pump that monitored his blood sugar and delivered the insulin that he needed directly. It was already attached to his belly. So there's all different types of, he was a type 1 diabetic. So, through the class, depending on what his blood sugar was doing, it was identifying, we're at this level. Okay, we're going to give this amount of insulin. So there's all types of devices. Assess if they need help with administration, or if they are unable or don't want to do it by themselves. So sometimes you may have to train a family member, a neighbor. You may be asked, hey, I know you're in nursing school. Can you help me with my insulin shots, what can you say if this is your neighbor? Can you help them?
Oh, that's a good question. I'm not even sure if I could. I mean, I could probably tell them where they should give it, but I would not reject it.
Okay, someone said no. Do you all agree?
I agree, because I don't want to be liable.
How are you liable if your neighbor asks you to give it?
Well, I don't want to. I mean, I'm not licensed yet, and then I just don't want to. I don't want to take that risk.
So say your dad, say you're not even in nursing school. And for those folks, before they did anything medical related, if your parent asks you or your relative asks you to stick this needle right here, would you do it?
Absolutely.
Okay, so there really is then there's not an issue.
Oh, okay.
You're right. You're not we're just good Samaritans. And under the Good Samaritan law, could you not do it?
I mean, you could do it under the Good Samaritan.
Nah. Yes, you can do it. If my neighbor says, hey, I don't want to stick myself with needles. I'm afraid, can you stick this right here? And you see that the insulin's there. They drew it up. It's where it's supposed to be. Okay. You can actually give it.
Oh, well, I just hope that it's really insulin and nothing else. Some people try to get you.
You would verify all of that beforehand.
Okay.
I would watch them. I need you to draw this up in front of me. And I would have a set of rules. Have I given insulin to folks before? Absolutely. Someone says, do your 5 rights.
Mm-hmm.
Can they sue us if we give it to them and say they die from it? Okay, so again, do the 5 rights. It's a good question, Moni. Do the 5 rights. That's why I said they would have to tell me. I would not tell me. I would have to see, give me this. I need you to draw this up for me right now.
Yeah, I would like to verify if that's really insulin.
Because I'm verifying that that's what it is. If you're licensed, yeah, you could teach them. They should be taught before they left their respective facility how to give. However, think about when you're in the hospital, you're being discharged, you're just so happy to be getting the heck up out of there. And whatever people are saying, you're just like, yeah. And they forget. Correct, Amy? So you can't refresh their teaching, but maybe some folks are just afraid to stick themselves. You can teach a relative if you don't feel comfortable doing it. Let me teach your son or your daughter to give it. So you can do that if you don't want to give it directly. You can just say, hey, you know what? Let me show them what to do. And Amy, you're right. Sometimes that they're embarrassed to admit at the hospital that they don't want to do it. Correct. So if that's your neighbor, and you can say, you know what, let me show you how to do it, because I may not be here and you may need that insulin and I don't want your blood sugar level to fall. So that could be your premise of if you don't want to be responsible on any level, to say, let me teach one of your family members how to do it, and the steps and the tips. Here's some videos that you can look at. Depending on your facility, Andrea, there are some facilities do have patient teaching papers for patients to go home on. I know a lot of the HCAs or medical cities, they had discharge instructions that were pretty thorough. For some reason, there are discharge instructions, but they are not as substantive as they used to be. They're just kind of general. So if you want some patient teaching, then that diabetic educator would be a good person to pull that from. So that's a very good question. But folks do forget, even I've forgotten after discharge. Oh, what did they say? Oh my goodness. So it's just, you're so glad to just be getting the heck out of Dodge. Just like, let me out of here. It's almost like you're getting out of prison.
Mm-hmm.
So just, those are things to keep in mind. Will they remember it when they leave? And how can you help them remember? But if it's just your neighbor next door and they say, hey, XYZ, then say, you know what, let me teach another family member how to do it. There's usually one person that will, you'll be able to teach it to. Amy, you can offer your neighbor to look through their discharge papers with them. So you can go through, hopefully they have them, and explain. There's patient navigators and social workers that can coordinate further. Yeah, they can. Care coordinators, they try to give them as thorough information as possible. They do that, but it doesn't necessarily mean when the patient gets home, they would have grasped all of that. So those are good places to start as well. So I'm not shooting it down. The patient depends on EMS a lot. There's programs like Dallas Fire Rescue Home, community advisors.
What kind of person wouldn't want to do that?
So for the EMS providers, they do now have the community health paramedic. So they are using them. I know in Tarrant County as well, the MedStar, they have community health paramedics to use for folks that do utilize the frequent utilizers is what they're calling them now. I'm not really sure because if you just, do an acronym, it would be FU. So I don't know. Moving on. But they do have the frequent utilizers that the community health paramedics or the home community advisors from Dallas Fire, they can also help with that process too. So that's kind of their job, but they have to be in that system first. So they have to have a physician that identifies them as a frequent utilizer in order for EMS to come out and actually treat them. So, but these are all good resources. All right, so back to the pharmacology part. 90% of the people with diabetes will need oral agents, insulin or both, in addition to diet and exercise to maintain their blood sugar levels. Choice and dosing of oral agents and or insulin is highly individualized, so it's not a one-size-fits-all. They need to be taught the name of the drug, how it works, the dosage they need to take, when to take it, how to store it, and possible adverse reactions. They need to be taught the 15 by 15 rule to treat hypoglycemia. So, the patient needs to ingest 15 grams of sugar, wait 15 minutes, then repeat it until the hypoglycemia stops. Some other common items that can give them that 15 grams is 1 ounce of chocolate or a half of a small candy bar, 5 lifesaver candies, 6 ounces of Coca-Cola, 6 ounces of orange juice, or 4 ounces of apple juice. They need to understand that hypoglycemia can occur both with injections of insulin and with some oral hypoglycemic agents. In case of insulin, they need to be taught how to store, prepare, and inject the insulin. So how to draw different types of insulin in the same syringe if appropriate. So clear insulin is drawn into the syringe first, then cloudy. Remember we talked about that in lecture. Patients should be taught the onset, the peak, the duration, and when they need to eat in relation to their shots. Medications should only be taken as prescribed. They should not self-adjust their medications. So I'm gonna give myself a little bit more because I'm getting ready to eat this cake. Not quite the thing to do. Monitor blood sugar levels at various times of the day, so the AC and HS, as directed to assess the responses of the medication, and this is going to depend on what's prescribed. So common side effects, shaking, sweaty, dizziness, lightheadedness, confusion, and slowness to respond. That's if they're having if they're going hypoglycemic, so we need to let them know what to expect. Type 2 diabetics, they often assume that, once they start taking the pills or the insulin, then their diet and exercise is no longer important, and that's not true.
Ms. Bridget, I have a question.
Okay.
You were saying that some patients, whenever they're so, oh, I'm about to have this piece of cake, let me go ahead and give myself a little bit more. So what is the right process to handle that? Let's say I am going to have a piece of cake in the next minute. Should I just wait till I eat the cake and then administer?
No. So, okay, so if we're going to eat cake, you are expecting it to go up. But remember, if you give yourself too much insulin and now their blood sugar drops to 50, because you have to look at how your body's going to react to the extra insulin.
Gotcha.
So this is why they can't just make those kinds of decisions without proper follow-up. And
So it's
no one
best
would
to
tell-
go ahead and eat and then administer after you taking your
No,
glucose
it's
level.
how about let's not eat this cake?
Tom can help you find that card.
Because, or if you eat it, just understand your blood sugar level is going to go up. But the answer to this is not to go ahead and take extra insulin. Because
Gotcha.
even 2 units of insulin can be detrimental. 1 unit of insulin could be detrimental. So this is why you don't want to playing with the insulin.
Understood.
Someone says,
yeah.
would it be a good idea to exercise after that cake? Yeah, that'll help bring some of that down too. But now you're still worried about hypoglycemia. So the
Yeah.
key here is to teach them the right things to do with the diet part, not try to manipulate the medicine part. Does that make sense? Leave that to their physician.
Absolutely, yeah.
So not to take it upon themselves to, I'm going to take 1 or 2 extra units. It's not that much, and it may be the one thing that puts them in hypoglycemia. So that's like you giving yourself 2 units of insulin right now. So it's only 2 units, but that 2 units can be detrimental because number one, you don't know how low it's going to drop your blood sugar. You don't know what your blood sugar is currently. And even if you were going to eat pancakes with syrup, that insulin may still, be detrimental to you. Does that make sense?
Yeah, absolutely. Thank you.
Okay, so just, stress that they focus on the diet part, the exercise part, pharmacology, that's to the medical professionals.
Prevention versus the consequence later.
Right. Because a lot of folks think like that, so you have to go ahead and clear that mindset up really quickly. Okay?
Yes, ma'am.
But we do need to let them know that, just because they're taking pills and insulin, that they still have to do their diet and exercise. That is still important to help maintain an effective balance. Their current meal plan and exercise program should be continued. Medications never replace a good diet and exercise. They need to be stored appropriately, keep them away from pets and kiddos. Oral hypoglycemics can be lethal and are common sources of toxicities in kids and pets. All right, so here's our progression. She starts having concerns about burning and tingling in her feet. I've heard many people with diabetes can lose their toes or even their feet. This is the time that you take to teach her about neuropathy and foot care.
Ms. Hudson, can I ask a question real quick?
Go ahead.
Okay, I didn't mean to cut you off, but remember you said 15 rule? I just posted a question right now on the
I'm looking
chat.
at it now. So
And-
a type 1 diabetic tells the nurse she's feeling lightheaded. The student's blood sugar is 60. Using the 15-15 rule, the nurse should give. Okay. What's your question?
So it's there. I mean, I excluded two out of the 4 that didn't go with it, but it was a choice between the carbs and recheck 15 or give juice checking 15. But the right answer was carb instead of juice.
Because 60 is your low end.
Right, because it says
So it's
juice.
not like 32.
Okay, that's all. Okay, I'm sorry.
No, you're fine. I just caught that though. I saw that and I was like, let me finish this and then I'll go get to it.
Okay.
Okay. All right. So this is what we're going to tell them about the neuropathy. Sorry about that, Ricky. So they're going to have nerve damage, and it can manifest as pain, tingling, pins and needles, or numbness. So high glucose levels over time damage the nerves and alter how they send signals. And that can be anywhere because that can happen in the heart. So they may not feel chest pain. Okay. Overall treatment is aimed at to relieve or prevent the progression. It's important to control the glucose, stop smoking, because What does smoking do to vessels?
And doesn't it like it shrinks it or it has
Vasoconstriction.
yeah.
Right, vasoconstriction. And good, Rosalinda, constricts. So it's important to exercise and be diligent about good foot care. So that's checking your foot on the bottom of their feet on a regular basis. That B vitamin is good for nerve cells, so that will be good for them to also, look at taking to help assist in that process. No diabetic education program would be complete without addressing good foot care. What's the 7 points you need to include about proper diabetic foot care?
That's a good question. Oh.
Comfort, that's correct. Comfortable shoes, having good traction, not wearing constricting material. Check your feet, wash your feet, wear shoes on a consistent basis. So, when I moved to Texas, I saw a lot of barefooted people. I'm like, I wouldn't dare put my feet on the ground. I mean, all types of things have crawled on there, peed on there, pooped on there, puked on there. I'm all set. Keep your feet hydrated with lotion. Absolutely. How about going to a podiatrist for your nail care?
Oh yeah.
So inspect the feet and in between the toes regularly using a mirror to check the areas that are unable to be seen. That's by Gannon. So here's that mirror that Kay Gannon was talking about. Wash your feet. Dry your feet thoroughly. Don't put a whole bunch of hot water because if you have nerve damage, then how do you know you're not burning your feet? Wear properly fitted shoes. Check the shoes daily for cracks, pebbles, nails, loose linings, irregularities that can irritate the skin. Check socks for irregularities, uneven pressures. Avoid high heel shoes or pointy-toed shoes because now your feet are jammed up in there. Don't walk barefoot, is what I was just talking about, or in stocking feet. So don't wear shoes without socks. Don't let your feet get too cold or too hot. Check the temperature of the bath or shower to avoid burns. Moisturize the skin. So use lotion in between the toes. Try not to use lotions with alcohol because that's cause more drying. So use more like body butters. Cut toenails straight across and file sharp edges. Patients with peripheral neuropathy or peripheral arterial disease or poor vision should not trim their toenails. So that's where the podiatrist would come into play. If you notice anything abnormal, then see a podiatrist very quickly. The slow healing process because they do have delayed wound healing. Avoid using chemicals, razors, sharp instruments to self-treat corns or calluses. That's a good one. Or ingrown toenails. Report and seek prompt medical attention. No matter the day. Don't wait for weeks because people can now develop sepsis. Have a routine inspections. This is a particular device. So this looks for, this test checks protective sensations. So loss of sensation places the patient at risk for more injury. I think the 7, 1, 2, 3, 4, 5. Yep, that'll be 7. Questions? So just kind of, people do have toes amputated. When you start seeing 30 and 40-year-olds getting, part of their foot chopped off because of diabetes, that's ridiculous. So meticulous foot care helps to reduce the amputation rate by 50%. That's significant. I think that's the end of that. Oh, nope. So given all the information in the foregoing scenario, what diabetes-related complications do you believe they're at most risk for and why?
I would probably have to say the foot amputation because of the neuropathy. She's starting to get the tingling sensation, and she's gaining more weight. She hasn't lost any weight.
Mm-hmm.
She's not following the regimen that the doctor prescribed her to, so she's at risk for a foot amputation.
Okay. Anybody else? Possible HHS as well as neuropathy. Great. That's a good one. Kay Gannon. Anybody else? Glaucoma. Excellent, Moni. Heart disease. Good, Andrea.
Oh yeah, she's at risk for a heart attack and a stroke.
Right. Kidney failure. Kay Gannon definitely about to lose an extremity because she has had poor control of her glucose and she's a smoker. So good, Daniel. All right. So number one is macrovascular complications, and that be coronary artery disease, stroke, peripheral vascular disease, and renal arterial disease. So that covers the kidney failure, heart attacks, strokes, and then just poor circulation. Her risk factors include diabetes, obesity, high cholesterol, high triglycerides. Her HDLs were super low. Her LDLs were mega high. Hypertension, smoking, not exercising, family history of a heart attack. So those are all good ones. So just kind of a little note here that the clogging of many cell receptors, so that's what glucose, high levels of glucose contribute to. So has a negative effect on how fats are metabolized, and it contributes to plaque buildup. And brain, peripheral and coronary arteries. So the effects on the renal system contribute to the high blood pressure. So syndrome X or dysmetabolic syndrome is where you have the condition is linked to an increased risk of diabetes and heart disease. So it's also known as insulin resistant syndrome. So list 3 interventions to help reduce macrovascular disease.
She can stop smoking.
Yep, stop smoking. That Kay Gannon said the same thing. Bless you.
Thank you.
Anybody else?
I would have to say, the aerobic exercising, do the light walking at least 30 minutes a day.
Amy Lee said ADA diet. What else? Lower her fats and intake, educate about healthy fats to get the HDLs up and the LDLs down. Okay, Andrea. So stop smoking, aggressive management of high blood pressure, so salt intake, spiritual intervention, mind, body, and soul. I agree. And hyperlipidemia, weight loss through diet and exercise, aggressive glycemic control. So, I mean, pretty much all the things that were the reasons why she got them will be the reasons why she needs to stop, or the focus that she needs to have to help minimize. So if you're sedentary, then get up, start moving around. If you're eating a high fat content diet, then you know what? Cut back. High salt diet, cut back. Stop smoking so you can have better circulation. So all of those are good reasons or rationales to move forward. I think every time I say I think that'd be it to come up with a new one. All right, so now the husband is planning on having another child in a year or two. So she wants to know how having diabetes will affect this. So now what are we going to think about now?
How will it affect?
Uh-huh.
It will affect a lot of things.
More weight gain. Okay.
More weight gain, and I don't know what kind of personal life they have, but maybe they won't be intimate. I don't know. If you
No, let's think about the diabetes and health and pregnancy.
Well, how old is this woman?
She was 40.
Oh,
Kay Gannon, caused preeclampsia due to the high blood pressure, or eclampsia, the edema, gestational diabetes, both Daniel and I think it's Michelle. So those would be some of the things that would come through. So that would be the concern there.
Isn't the baby at risk for hypoglycemia?
Oh, she'd be at risk for gestational diabetes, right?
Right. Somebody already put that out there. Macrosomia, where the baby's gonna be pretty big, right? Affect the baby and the baby's risk for diabetes, can cause preeclampsia. All these are good. All right, so let's go and see what happens. So what basic information can you share? Pregnancies in persons with diabetes is a complex issue. So what can you share without, like overwhelming her? I mean, if she adheres to all the things you told her already, like stop smoking, good, Daniel. Because that definitely affects growth and development. Eating better, monitoring her, glucose levels, that can help reduce some of the, issues that she might experience. She may definitely be a high-risk pregnancy. Would a diabetic mother be considered to have gestational diabetes since she had it prior to pregnancy? No. Usually the gestational diabetes is brought on because of the pregnancy. So not someone who already has it, but it does mean that the monitoring of the diabetes needs to be just as tight because of the fact that she is a diabetic. So gestational means, pregnancy, but the mother has diabetic issues because they are pregnant, not because they already have diabetes. So it would be like you can have pregnancy-induced hypertension, which is pregnancy-induced high blood pressure. So the pregnancy caused the blood pressure to go up. Okay. Have her meet with a nutritionist and walk through the diet. Okay. And her glucose needs to be monitored often. Yep. Keeping the glucose levels as balanced over time as possible is important. So that was from Andrea, Michelle, and Moni. So good job. So let's roll through. So they have the women with diabetes have the same fertility rate as women who don't. Diabetic care. So basically, don't have her. If she's thinking that she can't get pregnant, she can. Diabetic care during pregnancy is important, and that it's improved greatly over the years. So women with diabetes and their infants are still at risk for a number of complications. So that's why I said she'll be a high-risk pregnancy. To reduce the risk to the mother and child is essential to achieve normal or near normal glucose levels. So the HbA1c levels for 3 to 6 months before conception, they need to be maintained through the pregnancy. They need to transition from oral agents to insulin before conception if they're type 2. Current contraception methods should be continued until they've achieved glucose goals and ready to engage in further preconception counseling. So that would be the feedback. So HbA1c is glycosylated hemoglobin test that monitors the glucose over an experienced time or extended time. And it basically gives the indication or the degree of irreversible glycosylation in the red blood cells. So those are the red blood cells receptors with glucose, and shows the measures of glucose control up to 100 to 120 days before the test.
You said 120 days?
Yeah, it's right there.
Oh, okay.
So up to 100 to 120 days before the test.
Oh, okay.
So things that can cause the glucose to fluctuate, you know, time of the day or fasting status do not affect this test. So they do have variable, the things that can cause fluctuation, but like the time of the day, when, if the person's fasting or not, or that's not going to make the test go up or down. Because when they are, Michelle asked the question, why do they need to translate to insulin? Because that's going to be their better management. They can better control the glucose levels when they're on insulin. So starting that process beforehand will help facilitate that better. And so here's your normal range for your HbA1c, 4.4 to 6.
Are you able to share that in the screen with us?
I'm sorry, can you say that again?
Are you able to share that in the screen with us?
Do you not see it there at the bottom?
Let me see. No, I have a black screen.
Really?
At least I do.
I can see it.
Can anyone see it?
I see it.
Yeah, I see it.
Okay. I was starting to freak out. All right, there's a lot of yeses that they can see it. So this just kind of gives you a list of blood sugar levels and what the H1Cs are, or the A1Cs, not H1Cs, but A1Cs. Okay. All right, so that's the end of that scenario. Questions? So that was a pretty long case study.
I have a question.
Go ahead.
Is there any way you can make that case study available for us to look at home to kind of go through it one more time? Because that was really a lot. Can you send out an email or something?
I can send you the case study. You'll have the answers already, but I can send you a blank one.
Can you send it with the answer?
I'm sorry.
Can you send it with the answer?
The answers already.
So I can view them. I mean, you can send both if you want.
Moni, you ain't no good.
Okay.
I'm sorry.
Don't try to memorize everything in the case study. It's an understanding. I bet you 10 to 1, you already understand it. So just keep certain things into perspective.
Okay.
So I'm not against sharing it, but just keep in mind, what are you trying to piece together? What are you trying to put together? So what are you trying to understand about the diabetes? Some of the things will repeat. The key elements that you should have taken away from that is diet control, monitoring blood sugar levels, foot care, checking for for wound healing or for ulcers on the feet. So those would be things that you should have learned from that. What things can lead to further complications, or what are complications of diabetes, which would be the retinopathies, the nephropathies, the neuropathies. That would be the things to take away. Vessels, the macro vessels, so your cerebral, your arterial, your coronary, and your peripheral arteries. Those are things that are affected. Those are all key things. Diet and exercise. How many times we talked about that? Stop smoking. So, make sure you get your eyes examined. I don't think we missed anything in that. Only thing we didn't talk about specific was specific oral glycemic agents, but that's in your book though, right?
Mm-hmm.
Okay. So those should be your takeaways.
Okay.
Not trying to study and memorize the case studies, but just understand what it is.
Mm-hmm.
All right, let's roll on to the next case study. Unless if you have to go, I understand because we're already past our hour and a half.
We're
So
good.
this one should not be as long, I don't believe. Give me 1 second. Make sure I get the right one. Hold on. While I have some of you on the phone, I went through your Lippincott. Do you all have an extra resource for drug calculations? Or is it just in the pharmacology chapter?
That is a good question. Lippincott.
Because I went through it and I didn't see a specific resource for drug calculations. So I was getting ready to ask you all, have you all purchased like the drug calculation book Ogden? I know some students have, but not all.
Some people don't have it because it didn't come with the book package.
Got it.
Yeah, I bought Hinky's Med Math.
Okay.
That's a good book.
I need every math resource there's out there.
Find one plan and stick to it. I'm looking for one particular thing. Give me a couple seconds here. Okay. All right, let me go to the next one. All right, so we're going to actually do a case study on Cushing's and talk about the difference between that and Addison's. So that's what we're getting ready to do now. Let me share screen. Oh, hold on. Oh, someone said ATI is really good for med-surg drug math calculations. Someone said they found pharmacology. So yeah, I didn't see anything for math calculations, which that's kind of depressing because in your resources, you should have something related to that. All right, sharing screen. Oh, got to pick share screen. Okay. And all right, so this is Cushing's syndrome. So you have a 3-month-old. You graduated, not a 3-month-old. You graduated 3 months ago, and you're working with a home care agency. One of your patients in your caseload is JS, a 60-year-old man with chronic obstructive pulmonary disease related to cigarette smoking. He's on home oxygen, nasal cannula for several years, 2 liters. 10 months ago, he was started on oral chronic oral steroid therapy. His current medications include ipratropium, albuterol, or Combivent. It's a combination. This is a beclomethasone, which is Beclovent, an inhaler. Dexamethasone, Decadron, which is a steroid. Digoxin, and Lasix. So that's cardiac glycoside, and then you have a diuretic. So on the way to his house, you make a mental note to check him for signs and symptoms of Cushing's syndrome. Why? Why are we checking for that? Oh. Because of chronic use of steroids. Correct, Kay Gannon. So Cushing's syndrome is caused by too high levels of glucocorticoid in the body, and it's usually mostly iatrogenic or associated with long-term therapy with synthetic glucocorticoids such as Decadron. So that's very good. What are some other causes of Cushing's syndrome? What any other cause? I just want to know what other things cause Cushing's. Too much cortisol. Okay. What else? Cancer of the pituitary, tumor. Okay. Anything else? All right. So when we're looking at whether it's Cushing's or Addison's, so we're looking at the adrenal cortex or the adrenal gland, so pituitary gland tumor, adrenal gland tumor. We're looking at steroid hormones, aldosterone, and cortisol, the 3 things. So our adrenal cortex releases our corticosteroids, which is going to be our cortisol and our aldosterone, and the sex hormones. Aldosterone is a mineral corticoid, and cortisol is a glucocorticoid, right? So what are the functions of aldosterone? What's the main function of aldosterone? What does it do? Because this was the stuff you should have read for Tuesday's lecture anyway. Blood pressure, okay, regulates the blood pressure via what system? So what's that whole trail? So the renin, angiotensin, aldosterone system. So remember, angiotensin 1 converts into angiotensin 2. Where does that happen? In the lungs. That's where that becomes a potent vasoconstrictor. But when that happens, then it releases aldosterone. And what's significant about aldosterone? It retains sodium or causes fluid retention, but it also secretes potassium. All right, cortisol, that's our stress hormone. So usually when our body's under stress, cortisol will be released. How does cortisol relate to glucose? It raises glucose. Excellent. Let me see who that is. Marie. Thanks, Marie. So if your cortisol levels are high, then your glucoses are going to be crazy high. So blood sugar increases under stress. And does that happen for adults or kiddos? That your blood sugar increases under stress? Adults. What happens for kiddos? And that was Kay Gannon. Daniel, it goes down. And Kay Gannon, hypoglycemia. Amy, decreases. Excellent. All right, so cortisol also helps the body to deal with stress like an illness or injury. We've already talked about the glucose. It also breaks down fats, proteins, and carbs. And it helps to regulate electrolytes. So with the negative feedback control, we usually have, you have the hypothalamus that's going to release corticotropin, that corticotropin hormone, so the CRH. And then the pituitary gland was going to release our adrenal corticotropin hormone, or the ACTH. And when the CRH is released, then it causes the adrenal cortex to release the cortisol. So that's kind of the process. So if we have a break or a problem in that area, then we're more than likely going to have, that's where we're going to see our deficits, correct? All right, so Cushing's is hypersecretion of the cortisol hormone. So it only deals with the cortisol. So there's an outside cause, which is usually like a medical treatment. So glucocorticoid treatment, which is what somebody said that earlier. Hang on. I'm going to give him credit for it. That's what Daniel said earlier. That would be an external cause. You're correct. So any type of prednisone therapy. So anything with those sones on the end, so SONE, so dexamethasone, prednisolone, those ONEs, that's going to be your steroid medications, okay? What's the difference between Cushing's disease and Cushing's syndrome? Because here we're talking about syndrome. So what's Cushing's disease? We're looking at external versus internal, correct. So would Cushing's disease be more internal or external? Cushing's disease is more internal. Thanks, Daniel. Thanks, Kay Gannon. So there's an inside cause that can produce too much cortisol, which will be the internal, that causes Cushing's disease. And that's going to be when the pituitary gland is producing a lot of ACTH, so the adrenal corticotropin steroid, which will then increase your cortisol levels, okay? So we did list tumors, pituitary gland tumors, adrenal gland tumors. They can produce too much ACTH, and that person can end up with Cushing's disease, okay? So syndrome is going to be caused by medication. Disease is going to be caused by things like tumors, genetics. That's going to be your disease component, okay? All right, so let's go on to question 2. So just a little intro about that. So we just differentiated between Cushing's disease and Cushing's syndrome. So although syndrome is most commonly iatrogenic because of long-term use of steroid therapy like glucocorticoids, Cushing's disease is caused by an excess adrenal corticotropic hormone or production of the pituitary tumor called an adenoma. All right, so your assessment findings show that JS has COPD or possible Cushing syndrome. So place an L beside the symptoms consistent with COPD and a C next to those consistent with Cushing syndrome. So there's 10 of them. So what would be number 1? And you know, this is interactive. All right, so let's see what we have. So COPD is correct for number 1. COPD for Kay Gannon. Thanks, Tiris. Anybody else? So barrel chest is COPD. What about full looking face or moon face? That's Cushing's? Okay. Thanks, Amy and Kay Gannon. Blood pressure. Is that COPD or Cushing's? And put a number by it so I know what you mean. Say like 3C or 3L. So that would all be Cushing's. Pursed lip breathing when the patient is stressed. COPD, correct. COPD. Striae over the trunk and thighs. Cushing's. Thanks, Kay Gannon. Thanks, Daniel. Thanks, Amy. Acne. I'm sorry, skip one. Bruising on both arms. That is still Cushing's. That's still Cushing's. Yep. Thanks, Kay Gannon and Michelle. Thanks, Sadi. What about acne? Number 7. The skin issue, so it's going to be Cushing's. Correct, Kay Gannon. Diminished breath sounds throughout the lungs. Number 8. COPD. Thanks, Daniel. Thanks, Amy. Or thanks, Michelle. And then someone says iPhone, so I'm not sure who that is. Truncal obesity. Truncal obesity with thin extremities. That's Cushing's. And then the last one, supraclavicular and posterior upper back fat for 10. That's going to be Cushing's as well. So pretty much you should have LC, CL, CCC, LCC. So there's only 3 that are associated with COPD. And that's number 1, number 4, and number 9. All of them are Cushing's syndrome. So that's your signs and symptoms. So when you have Cushing's, we have increased cortisol. So we have stress, fatigue, skin. So it could be acne, they can have bruising, truncal obesity, which is basically small arms and legs, but the torso portion is big. Ecchymosis or bruising, increased blood pressure, striae to the extremities and the abdomen more particularly. So they have those purplish lines, and it's not stretch marks, because stretch marks are usually white in color or like a yellowish white color or tan, but not purple. Moon face or round, excessive body hair. So basically you can end up with hirsutism, especially women. So they take on male characteristics. Dorsal cervical fat pad or the buffalo hump is another one that they can develop. Blood sugars are extremely high. Depression, and then women can have reproductive issues like amenorrhea, so that means they don't bleed. Menorrhea means bleed. A means no or without. Males can end up with erectile dysfunction. So those are some concerns that they can have there. And that was in the PowerPoint in the beginning when I put down the different signs and symptoms that can be displayed with endocrine disorders. All right, so just covered all of this component here, the signs and symptoms related to Cushing's syndrome. All right, number 4. So you inform the physician of your assessment. And so the physician believes that JS has developed Cushing's syndrome and decides to change his prescription from dexamethasone, Decadron, to daily prednisone, Deltazone, given on alternate days. Why? Why the change? Anybody? Slow the reduction or slow the amount of corticosteroid, okay, to try to reduce the amount of cortisol produced, okay. Good, Michelle. So administering it on alternate days may decrease some of the side effects and diminish the degree of hypothalamic pituitary adrenal suppression. So usually with dexamethasone, we have adrenal suppression that lasts 2 days or more, and it would not be suitable for alternate day therapy. The adrenal suppression associated with prednisone is shorter. All right. So identify possible consequences of suddenly stopping a steroid. What happens? Oh, I can't pick up those. Or oh, there we go. It could shock the body. Okay. No, you can't stop abruptly using steroids. Remember, if you've ever taken a steroid before, like your physician gave it to help with like a sinus infection, it's always in a stair-stepping motion. Suppression of the adrenal gland, someone goes, I don't know. It's okay. So when you're receiving that therapy, the feedback system among the hypothalamus, the pituitary, and the adrenal glands are suppressed. So if you stop it, then the patient can all of a sudden have an emergent sign or symptom of acute adrenal insufficiency. So that's why we don't do it. So return of normal adrenal function can take several months, so steroids must be withdrawn slowly. It's kind of like a rebound. So you advise JS to take the prednisone at breakfast. Why? Besides the fact that, you know, prednisone make you eat a bunch, what's the other reason? What happened to, if anyone's ever taken it, taken a steroid before, there's something that usually happens in the middle of the day. What is that? Anybody? Yeah, cortisol is produced naturally in the body, but what happens, do you get sleepy in the afternoon when you take prednisone? Come on, guys. Because you should have, this is a material you should have already read, so it should be in your notes. Can't sleep. You get more energy. Thank you, Michelle and Marie. So taking it in the morning mimics the body's natural production. Taking it with food decreases the incidence of the GI and upset stomach and ulcerations, but you're going to get a burst of energy in the middle of the day. So that's the reason why you want to take it in the morning, because you don't want to take it in the evening or in the afternoon. You'll be up all night. So someone said that's what she said, can't sleep. Cushing syndrome can affect memory. Patients can easily forget what medications have been taken, especially when there's several different meds and some are taken on alternating days. So what can you tell JS to help them remember to take their medications as prescribed? Select specific days of the week. Okay, get a pill calendar, write it down, or place an alarm on the phone. Pill organizer, routine. You know, link med times to activities. Good suggestions. Marie, K. Gannon, Michelle, Amy Lee, Rosalinda, Andrea. So those are all good ones. All right, so help them develop a checklist or a pocket calendar to monitor medications. This can also be useful for monitoring weight and blood glucose and blood pressure. Recommend a divided container in which pills can be placed in advance. This way, they can immediately see whether they've forgotten it or not, specific date and time. So help them plan whereby he takes his medication at times of the day related to other activities, which is what Amy said, such as meals or when he brushes their teeth at night. They do have a pill dispenser, so that could be another option where you do have the pills in there. And I'm not talking about the plastic ones. They actually have a battery operated one, so it can go off at certain times of the day of when to take the medication. So they can just carry the whole pill container. And then when it comes time for him to take the pills, it'll slide to that pill and to that container, and then all they have to do is take the pills out of it, and then it'll go to the next one. But it won't move to the next one until time. So JS states that his appetite has increased, but he is losing weight. He reports trying to eat, but he gets short of breath and cannot eat anymore. So how would you address this problem? Small frequent meals, smaller meals. Okay, excellent. So dietitian for a thorough assessment, including weight and body fat distribution. Because of the altered carbohydrate and fat metabolism, his diet should be oriented towards higher protein, higher fat, low sodium, and low cholesterol. So that's the nutritional part. Good, K. Gannon, with the high protein. Avoid carbohydrate loads at any meal. So those big carbohydrate dumps. Carbohydrates increase the CO2, which contributes to increased respiratory failure. Since they're having difficulty eating because of the shortness of breath, they should encourage the small, frequent portions and more frequently. Not to use any expectorants or bronchodilators immediately before meals. Expectorating mucus and the taste of inhaled medications are not conducive to eating. So have him complete his breathing treatment 1 hour before eating and then rest up. Then rest to help minimize the dyspnea and the anorexia. Make sure he's sitting up, good moaning. Meals should be taken with minimum distractions. If he's responsible for preparations of the meals, then look at energy conservation and with regard to meal preparation, like sitting on a stool while cooking, or maybe do like a crock pot meal. So then you can just, all you would have to do at that point is just heat it up. All right, so let's look at number 9. So you ask him questions related to presence of gastric discomfort, vision, and joint pain. Why are we interested? Because he is taking a steroid, but why? What specifically? How does steroid affect vision and joint pain and GI discomfort? So you're on the right track, Michelle. Okay, decreased inflammation, Daniel, okay. So they're more susceptible to reduces calcium in the bones. Good, Amy. So these are side effects of long-term use, and there's a barrage of side effects. So more specifically, since they're only asking about GI, vision, and joint pain, so as far as GI, they're susceptible to peptic ulcers, cataracts, and then osteoporosis. So that's why that would be questions you want to ask. But go back and look at all of the negative side effects related to long-term use of steroids. So what's the difference between a glucocorticoid and a mineralocorticoid effects of prednisone? What's the difference? Have you guys looked at your meds? How they're metabolized? Okay. So the question is, Michelle's asking, does osteoporosis cause issues with the blood production because it is made in the bone marrow? It could. With osteoporosis, you have density of the bone, so the bone is more susceptible to breaking. So if you would have some loss of blood production if you have damage to the bone itself. It was a question of how. All right, so prednisone is an intermediate acting glucocorticoid that has minimal mineralocorticoid activity. So suppression of the inflammatory and immune responses is the primary effect of prednisone. So there should be a minimal sodium and water retention, if any. How would your assessment change if they were taking a glucocorticoid that had significant mineralocorticoid activity? Would you reduce it or give more? What would you do? Not sure? Maybe increase? So the signs and symptoms. So if you're taking a glucocorticoid that had significant mineralocorticoid activity, remember the mineralocorticoid, there should be minimum sodium retention. So you would pay greater attention to assessing for signs and symptoms of excess fluid, neck vein distension, decreased urinary output, peripheral edema, respiratory difficulty, crackles, weight gain, potassium and magnesium deficits. So go back to what do mineral corticosteroids do and what do glucocorticoids do. And that helps you figure out if you're taking a glucocorticoid that had significant mineralocorticoid activity, then that will, if you have more of the mineralocorticoid activity, what would you expect to see? Does that make sense? Okay. Someone says Google mineralocorticoids. Oh, they're telling me. I'm sorry. Mineralocorticoids are produced in the adrenal, yeah, and influence salt and water balances. Okay, but how though? How, Rosalinda? We're not at the loop of Henle, but I want you to focus on what do they do to the body directly? So even if how do they influence the salt and water balances? Cause excess cortisol, okay. So if you have excess cortisol, what did we say cortisol does? Increase sodium and potassium. We definitely know that cortisol is going to, especially the aldosterone component, no, not cortisol, but aldosterone, it's going to secrete the potassium, right? And we already know that it was going to, the function of your, the function of aldosterone retains sodium and secretes potassium. So if we're looking at that from that perspective, then that's why we would have our excess weight gain, our excess fluid, JVD, urinary output would be minimized because we're going to be retaining fluid. Well, if it secretes it, then would the potassium, if you have more of the aldosterone, wouldn't that be more potassium? Okay. You got it, Michelle? Okay. So go back to your functions. Yes, aldosterone keeps the sodium, which retains the water. Remember, water follows salt, or salt follows water, whichever one, however you want to put it, but the two of them are always together. Potassium is released, meaning it goes up from the aldosterone. So when that hormone is produced, potassium is also being released, not decreased. So when you're looking at trying to know or understand the difference between steroids or any medicine, look at how it works on the body. What's the impact? So if this hormone is released, if it's going to make your sodium levels go up, then understand that if you have more of it, then you'll have higher sodium levels. If you have less of it, then you have lower sodium levels. Does that make sense? Okay. So here's the list of medications. Whoops. So based on what you know about the side effects, now we're going to talk about the loop of Henle because that's more specifically related to your diuretics, and it is going to be related to the steroids. Discuss the potential problem of administering these in combination with digoxin. So you would actually have to go back and look at how does digoxin affect the kidneys, how does the diuretics affect the loop of Henle, which it should increase diuresis, right? What steroids do, and then that will kind of look at, do we have a good mix of meds? So I'm going to slide on down to it. So although the prednisone has less mineralocorticoid activities than other steroids, the combination of prednisone and Lasix could lead to hypokalemia, hyponatremia, and hypomagnesemia, because now we have less of the mineralocorticoid activity. So hypokalemia will increase the risk of DIG toxicity or DIG-induced dysrhythmias. And that, when we get to fluid and electrolytes, that's going to come back up. So for right now, just understand that if we have, if we add combinations of these meds, we can have electrolyte imbalances. So what signs and symptoms you need to assess for an infection and why? Fever, okay. Increased heart rate. So, because you have WBC. So corticosteroids they mask the signs of infection. Steroids affect the immune system. So those prednisones and other corticosteroids can mask signs of infection, impair the body's natural immune response. So if they take it, then they have to understand they're more susceptible to infections and can develop a serious infection compared to those that are healthy individuals. So WBCs are the things that we definitely want to look for. So apply these, select all that apply. Which one would be, we talked about fever, but yeah, what else? Let me just move on. So out of A through F, what would be the ones we would select? Pain, fever, palpitations, and edema. So A, B, D, and F. A, B, C, and E. We got E. Yep, A, B, C, and E. And here's the reason why. So fever, we all know that that's usually a telltale sign the body's working overtime, right? Pain at the site of the infection, unusual drainage and loss of function may occur. Palpitations and swelling are not usually present. Realizing that he's susceptible to infection, you review with him ways to reduce the risk of infection, and then identify 4 major points to include. So we're going to avoid people with infections, especially children in large crowds. Take care of normal activities that might expose them to pathogen. Hand washing. Yep. Handling soiled standing water and pets. Wash hands frequently. Ensure meticulous personal hygiene. So bathing and brushing teeth. Meticulous care of any wound. Report any signs and symptoms of infection. So last question, I believe. In addition to the measures to reduce infection, what other things we can do? We're just still on Cushing's. What else can we do? D, E, and F, okay. C. I know what you meant. All right, so C, D, E, and F. So patients with Cushing's secrete excess amounts of cortisol or corticosteroid that acts to retain sodium in water, resulting in hypernatremia and edema. So daily weights are the best means to monitoring the volume status. So call our doctor if we have weight gain 2 to 3 pounds in a day. This is an indication of volume overload. And that's pretty significant across the board with any volume overload patient or potential for volume overload, like your CHF patients. Patients on steroid therapy must also follow a diet that limits salt intake and increases potassium intake, as the kidneys are retaining sodium and excreting potassium. Further, furosemide should not be taken in the evening because otherwise the patient's going to be up all night peeing. Call the doctor if the pulse rate is less than 60 because that can be a sign of digitoxicity. High fluid intake can cause volume overload and make their pulmonary symptoms worse. So anyone that has volume overload is at risk for respiratory compromise, or take medications that can put them at risk for volume overload is at respiratory compromise. Does that all make sense? Clear as mud? No one's talking anymore? No? All right, so let's talk a little bit about Addison's disease, which is the other portion of Cushing's. So here we have a decreased amount of, how can you tell what's involved with Addison's? Is it, because Cushing's is cortisol only, right? It only deals with cortisol. So what does Addison's deal with? And we've been talking about cortisol, but it's because it's the stress hormone. Correct. It's both aldosterone and cortisol together. So is this something you can develop from taking a medication, or is this something that's genetic? What is it? We're looking at Addison's disease. It's genetic. It's an autoimmune disease. Okay, so the body starts attacking its own adrenal cortex. You can develop it from cancer. You can get it from tuberculosis. You can get it from trauma. Okay. So instead of having too much cortisol and aldosterone, we have too little cortisol and too little aldosterone. So if you want to remember, which hormone is involved, then Cushing's would be involved with cortisol, and with Addison's, we need to go ahead and add aldosterone to it. So here we have low steroid hormones. Our sodium and our sugar levels, are they high or low? They're low. Thanks, Kay Gannon. They're a little bit low or significantly low? Significantly low. We also have low cortisol, low glucose, aldosterone. We're going to retain sodium. We're going to have salt cravings. So secondary to the low sodium. Are we running around, jumping around, or are we just kind of tired, weak, and fatigued? Thanks, Altoine. We're going to be tired, fatigued, weak muscles. So what are our electrolyte imbalances? High potassium, yep. Low sodium, correct, and there's one more. Yep, decreased sodium, there's one more. What happens to the calcium? Does it go up or down? It goes up. So we have increased K, increased calcium, and decreased sodium. Reproductive changes for ladies, irregular menses; for guys, erectile dysfunction. BP up or down? Down. What are we at risk for if it's low in reference to the cardiovascular system? Hypotension, cardiovascular collapse. Good, Daniel. All right, what about skin? So we had fragile, easily bruised, acne skin for cortisol, for Cushing's. What do we have for Addison's? Okay, so it's tanned, it's bronze. Thanks, Daniel. What else? Pigmented, okay. Kind of a brownish orange color. And that's a hallmark sign for Addison's disease, kind of orange peely, right? What does hallmark mean again? Dry from dehydration, Trump. Oh, like the Trump card. Is that what you mean, Ricky? Someone goes Donald Trump. That is funny. So basically, you mean it's the symptom that makes or sign that makes that disease that disease or that condition that condition. What about their psyche? Will they be super excited or depressed? Depressed. Good, Kay Gannon. So they could have diarrhea or nausea. So that would be their signs and symptoms. All right. So what will be our interventions? What do we need to monitor for? Oh, constipation. Will they have constipation or diarrhea? Which one, guys? Diarrhea. Okay. So what things do we want to monitor for in Addison's disease? So watch glucose and potassium levels. Okay, so we really want to watch for hypoglycemia and hyperkalemia, right? Because we had an increased K, increased calcium, and decreased glucose. Thanks, Ricky. So how do we fix it? Now, would it be for, someone said BP, is that high or low BP? Terrace? Low, excellent. High protein diet, do we want to give them a high protein diet? And if so, why? Because of the muscle weakness that they are experiencing? They're going to do replacement therapy. What kind of replacement therapy, Ricky? Replacement of hormones. Okay, so let's kind of go in order. So we're going to monitor for hypoglycemia and hyperkalemia. We're going to administer hormone replacement therapy. So we're going to replace the cortisol because we don't have it. So we're going to give them something like prednisone, hydrocortisone. We're going to educate them on when to call the doctor. So if they're under stress, should they increase their dose? Or would they need to increase their dose? Let me just ask that question. So if they're under stress, yes. Thank you, Kay Gannon. Anytime a patient that has Addison's disease if they're under significant stress or illness, then they need to increase their dose of either prednisone or hydrocortisone or whichever hormone replacement therapy they're on. It's critical that we tell them to take their medications on a regular basis. Don't stop them abruptly, and make sure they consume enough salt. Wear a medical bracelet. We definitely need a high protein diet. We've already covered that. What if they're going to do aldosterone replacement? What medicine would they get? So instead of going with, we did cortisol, so what aldosterone medicine would we give them? Anybody look that far into it? Florinef, that is correct. Thanks, Daniel. Florinef is an aldosterone replacement medicine, but they have enough sodium, so we need to make sure they eat enough sodium. I'm sorry, they need to eat enough sodium. So we want to tell them to avoid stress. Well, prednisone, Ricky, is the cortisol, so we're looking at the aldosterone component, which is Florinef. They need to avoid stress and illness and strenuous exercise. If they have strenuous exercise, illness or stress, they're going to end up increasing. That's okay. They're going to end up increasing their cortisol level, or their cortisol, or their replacement therapy, their hormone replacement therapy. What's the worst case scenario of Addison's? Crisis, Addison crisis. So this happens, when do you get Addison's crisis? Good, Kay Gannon. Low, I couldn't get that one. So infection, okay, low cortisols. Fail to take their meds, if they don't take their meds on time, and it's not enough dosing. So they'll have Addison's crisis when they stop taking their medicines or stop taking them appropriately, or they don't have enough in the dose to manage their Addison's disease. Or barely have any cortisol left, then that will be when they develop Addison's crisis. What's the signs and symptoms related to Addison's crisis? I think someone put that up earlier. Or signs and symptoms that you'll see. So the syncope, shock, super low blood pressure, back pain, stomach pain, leg pain, severe vomiting and diarrhea, and headache. How will we treat that if they have Addison's crisis? IV what? We're going to give them IV cortisol is what we're going to give them. So we're going to treat the cortisol levels. If they have Addison crisis and their cortisol level is close to 0, and they're at risk for infection and all kinds of other things. So we're going to give them IV cortisol like Solu-Cortef. Yep, electrolytes, saline. Now, what kind of saline? Do we want to give them normal saline or D5NS, Amy? Give me a specific, Kay Gannon. We are going to check vital signs frequently. We're going to check blood sugars. We're going to check sodium levels. We're going to give them D5NS. Perfect. So for the treatment for the Addison's crisis is IV cortisol, D5NS, and we're giving the D5NS so we can increase their sugar, increase their sodium, and increase their blood sugar. Okay. All right, so the other thing I didn't talk about is how do we treat Cushing's? So we should be preparing for them to have surgery, like a hypophycectomy, which is basically removal of the what gland? And this is for patients with Cushing's disease, not the adrenal, a hypophycectomy, because otherwise it'll be an adrenalectomy if we're going to do the adrenals. So I'm asking, what's a hypophycectomy? Removal of the pituitary gland. So we will prepare for that, or we will prepare for an adrenalectomy, which is if they have an adrenal tumor, we're going to remove that. We're going to educate the patient about, cortisol replacement therapy after surgery, but not because they're not going to be producing it on their own. We're going to watch their blood sugar levels. We're going to watch their potassium levels. We're going to watch them for risk of infection, skin breakdown, and emotional support. That's on the Cushing side. So we're going to watch them for hypokalemia, hyperglycemia, infections, risk of skin breakdown, and then emotional support. So what I would do is kind of do a comparison and contrast between Cushing's and Addison's disease. And that's how you kind of understand the difference between the two, or, which one has what. Other things we can do for them, for Addison's, is to make sure we reduce noise. So protect them from light and temperature and noise, because that will increase their stress levels. Will a patient with Addison's, so if they have hypocortisolism, is that a lifelong therapy? Yes or no? Yes. So they need to check their weights daily. They need to know that it's lifelong. It's not short term. Watch for falls. Watch for GI distress. So that would be some of the things we want to talk to them about. Any questions about Addison's or Cushing's disease? What's your question, Ricky? Or was that an answer to another question? Oh, okay. Answer to another question. Okay. All right. So I think we've been at this about 2.5 hours, or almost 3 hours. Thoughts? You guys are welcome. Is there any other questions that you have? Have you looked at your raising the bars? You're welcome. Make sure you look at those raising the bars in your course board. I would be answering those like crazy. Okay? All right, other than that, enjoy your Sunday. See you Tuesday. Be ready for the comfort component. We're going to talk about pancreatitis, renal calculi, but more specifically, pain management related to those conditions. All right, guys, we'll talk soon.